What's proposed in the proposed rule for MIPS?
Great question, Kyle. That's certainly the foundation of the quality payment program. Well, first is proposed to keep the performance threshold at 75, at least through the 2025 performance year. I don't see any reason this wouldn't be desirable, and don't see any reason why it won't be finalized. To keep the data completeness requirement at 75%, at least through the 2028 performance year. So they're looking a little ahead and proposing to keep it the same for a number of years now. Now, that can change in any annual rule cycle, proposed, finalized, and then go into place. But I don't see any reason this wouldn't be desirable, or that Medicare would not finalize the rule or keep it at 75% as they promised through 2028. Now, there's the usual fiddling with the measure inventory on all of the performance categories. No changes are proposed to the promoting interoperability measure set this year, and they're confirming the previous intention to end automatic reweighting for clinical social workers. But they'll leave all the other special statuses, small practices, non-patient facing, untouched, presumably permanently. Quality measures, there's 9 new measures proposed, including 2 new outcome measures, proposing to remove 11 measures from the inventory, update 66 of the measures, and leaving us with a 2025 MIPS CQM measure inventory of 196 quality measures. Now, I'm not going to go into details of any of those. They can all be found in the appendix attached to the proposed rule. So if there are measures you're particularly attached to and don't want to see ended or changed, check out the measures you like in that appendix. Improvement activities, proposing to add 2, modify 2, and remove 8 for a total inventory for 2025 of 100 measures. Now, there's one very important change to improvement activities. They're proposing to eliminate the weighting of improvement activities. Previously, there were medium and high weight activities. They're proposing to remove that infrastructure completely and just count activities. So MIPS individuals and groups on a standard are required to report 2 activities for a full score in improvement activities. Small practices and other special statuses, 1 activity is required. MVPs, 1 activity is required. Also, no change to the expectation that practices in alternative payment models still get a practice improvement activity score specific to that APM. Currently, all APMs are still getting full credit for practice improvement. Cost measures, there are 6 new episode cost measures proposed, 5 new chronic condition measures proposed, 1 acute inpatient medical condition measure, and changes to 2 existing cost measures. Now, there's a very important change proposed in cost measures. They proposed to change from the straight percentile ranking or decile ranking for scoring to a modified curve. They propose to take the median score from 5, where it now sits, up to 7.5, correlating, they think, with the performance threshold score of 75. So 7.5 out of 10 cost achievement points is what they propose for the median score, and then use standard deviations to spread out the scores from 1 to 100 or 1 to 10. What this will do is pin the bottom, keep the bottom pinned at 1 or potentially 0, pin the top score at 10, and so the people scoring at those levels won't have a change in their score, but that median score get moved up to 7.5 from 5. Now, they gave an example that says a practice where a slightly above average score would change the scoring from 2.3 in the current pattern to 7.7. So you can see this would raise that score dramatically. No one would actually have a decrease in scores from this change. So I don't see any reason not to support the change. I think it would be good for everyone and see more people able to meet the performance threshold and be in the incentive range. They're also suggesting another amendment to the topped-out measure treatment. That gets addressed almost every year. For measures judged to be important to specialties otherwise underserved by measures, they want to keep those topped-out measures and remove the 7-point cap, and then propose a flat benchmarking schedule from 1 to 10 points for those especially important topped-out measures. They'll abbreviate the top end of the scale, providing 10 points for anyone with a perfect 100% performance score. But skipping the scores in the 9s range entirely, with the next higher score to 10 being 8.9, which is a lot better than the current 7 points that a top-down measure gets. A raw score of 84% would earn 1 achievement points, with everything below 84% coming out 0. So pretty devastating on the lower end of the scale, but that's the nature of a top-down measure. They tend to cluster all at the top. I don't see any reason not to approve this. I don't see any reason why Medicare will not finalize this. Now, they're also proposing adjustments to the handling of multiple submissions. So there's two kinds of multiple submissions. First type is multiple submissions of the same type from the same entity, like Mingle Health submitting 2 different registry measure sets for a client, or practice themselves uploading with a practice administrator uploading 2 different sets of measures. Now, anytime the same entity submits the same measure type, they intend to go with the most recent, and that's what we've been experiencing as long as we've been in Medicare quality reporting. Submissions of different types or the same type from different entities, 2 different registries submitting competing or overlapping submissions, the most advantageous score will be used from those. Now, they're also proposing a reweighting option that's unusual for reweighting requests, in that it can be retroactive. It can be submitted later in the submission cycle for practices who don't submit data due to a third-party failure. So, and again, I don't see any reason why you wouldn't want that to be adopted, or why they won't adopt that into the final rules. I think that's everything fit to print about the MIPS proposals, Kyle.